probably centrally mediated pain state. MRI data has shown that fibromyalgia involves some alteration of central pain processing. The tender points, very important to know where these points are. Anteriorly over the sternomastoid, second intercostal space, the elbow, the knee, and posteriorly. This is one I found pretty reliably present. And that's here, over the sternomastoid superiorly, the interscapular areas, over the superior rim of the pelvis, and over the trochanter, the greater trochanter. These are important. So what's going on? I mean, these patients often have a collection of findings. Think of the fable of the elephant being examined by 6 blind men, and now compare that to the possibility of the patient. It's like an elephant being examined by 6 medical specialists. The neurologist sees a chronic headache or true migraine. The gastroenterologist sees irritable bowel syndrome, temporomandibular joint syndrome. Cardiologist sees costochondritis. The rheumatologist sees fibromyalgia. The gynecologist sees premenstrual syndrome. So these all overlap, but the entity is the same. Now we know that to the patient, truly, her complaints are real, and I'm convinced that the pain is real. And I'm also convinced that if a doctor sends this patient away saying that it's all in your head, you'll never see that patient again. I think that's not good, because she might fall into the care of a person who misdiagnoses or mistreats her. You might see her 5 years later after she's on cortisone, corticosteroids, and is cushingoid for an entity that really doesn't deserve that potentially toxic treatment. So we don't ignore it. Think about the generalized soft tissue pain syndrome, non-articular pain, fatigue. Often these patients can't function. They really can't. They may spend a great deal of time in bed. They can't do what what they're needed to do. There's no inflammation, and the neurologic exam is normal. So there is specific diagnostic testing and therapy for many of the psychological causes of chronic pain. So we're not going to give up. We're just going to try to compartmentalize her into a diagnosis so we will know how to direct our therapy. Now, in case 1, the laboratory studies were normal. Her symptoms had been present for 3 years. There was no evidence of organic disease. She was not significantly depressed, and somatization did not seem to be the primary problem. Thus, the diagnosis of fibromyalgia was made. So, as we see, it's primarily a clinical diagnosis. So now let's talk about case 2. Maybe the diagnosis is a little different here. 48-year-old woman, diffuse muscle pain, weakness, fatigue. Now this has had a gradual onset over the past year. Her life is in disarray. She was separated from her husband. She can't sleep, and she's lost 10 pounds. The physical exam and screening tests are normal, and despite your best efforts, you don't detect specific tender points. So here, our thoughts might turn more toward something different. Now, I need some help. What's the next step based on this information? You want to get a body CT, ACTH stimulation, tests for muscle disease, lupus, or considered depression or somatoform disorder. C's not bad, but right here, I don't think that's the best answer. C might work after you've ruled out other things. The answer that's preferred here, and I think I would agree with it, is considered depression or somatoform disorder. So you tell me, hey, Dr. Walker, I'm not a psychiatrist. What are you asking me to do? I have a very busy clinic. Patients are in and out. I simply can't do detailed work. But there are some questions you can ask rapidly that will help screen for depression. And we know this is important because depression is potentially a fatal disease. And I'm talking about big-time depression, serious depression. And let's remember that the very depressed patient is very skillful at hiding the depression. Sometimes we have to ask the right question and test to bring out the true diagnosis. So some fast screening questions are, what about anhedonia in the past month? The ability to perceive pleasure or joy. What about a depressed mood? Do you feel down, like there's no hope? And patients won't tell us this unless we ask them. If one answer is